Thank you, Dr. Sunita, and very good morning to all of you. I'm going to be talking about the indications, case selection, and pre-op considerations for tube implants. We know that implantation of glaucoma drainage device is a well-established surgical procedure. But as for any surgical procedures, we require to do a proper case selection. So if we were to look at the indications, broadly we could say that tube implants would be indicated in patients who have undergone trabeculectomy and they have a failed trabeculectomy. The trabeculectomy is no longer controlling the intraocular pressure, and that is the point where you can consider doing a tube implant. Literature and experience will tell you that there are lots of cases in which trabeculectomy is likely to fail. And these are the conditions wherein tube implants will be a great option. And as the trend is increasing, many surgeons across the world are opting for tube implant as a primary surgery also. So the conditions where trabeculectomy is likely to fail, some of them would include neovascular glaucoma, glaucoma post-penetrating keratoplasty, glaucoma associated with eye syndrome, epithelial downgrowth, glaucoma in pediatric age group which is refractory, glaucoma secondary to retinal detachment surgery or associated with inflammation or uveitis. When we are deciding between a trab or a tube, we can take some other considerations also. For example, you would know that studies have shown that after trabeculectomy, the number of anti-glaucoma medications required are slightly lesser than what would be required for a tube implant. So therefore, if you have a patient who has intolerance to glaucoma medicines or difficulty in administering the drops, you may consider a trabeculectomy in that case in favor of a tube. If there is a patient who has endothelial disease which is likely to be worsened by placing a tube near the endothelium, again trabeculectomy can be considered. Of course, you have an option of putting the tube elsewhere. Those options are available, but you can keep this in mind. If there is a patient with a crowded anterior chamber or a short crowded phakic eye, again a consideration may be given for trabeculectomy in favor of a tube. But there are several factors which will favor a tube implantation. For example, there is a patient who has had excessive scarring from a prior superior scleral surgery where the conjunctival dissection close to the limbus is difficult, or if the patient has inflammatory or uveitic glaucoma. If the patient intends to wear contact lenses, then the thin bleb might be affected if you are doing a trab. If a patient has high myopia or thinned out sclera, then again a tube would be more favorable than a trab. If the patient has difficulty in coming for a regular follow-up, if the patient is exposed to dirty conditions which might be occupational or recreational, again there is an increased risk of infection in a thin trab bleb. Then too you can consider a tube. So once you have decided that you want to go ahead with a tube implantation, there are few preoperative considerations which should be kept in mind. A careful preoperative examination and planning is a must. We must assess the mobility of the conjunctiva because we have to determine which is the best quadrant for the drainage implant insertion. We should look at the iris, preferably under high magnification, so we can detect neovascularization. A good assessment of the anterior chamber depth to determine if the tube insertion in the anterior chamber would be safe without touching the iris or the cornea. Gonioscopy to tell us about the location of the peripheral anterior synechiae which may interfere with the tube insertion intraoperatively. The lens status of the eye is important to note. The tube may be placed in a sulcus in a pseudophakic eye, and you can also choose to go by a pars plana route if it is in a phakic and a vitrectomized eye. And in case there is an eye with a cataract, you can think of a combined surgery too. When you're looking to select the glaucoma drainage device, because we'll be talking about the Ahmed glaucoma valve particularly today, but as a rule for a beginning surgeon it would be a good idea to go in for a valve device because the surgical technique is simpler. The localization is to one quadrant without manipulation of the adjacent rectus muscle, and the IOP control in the early post-operative period is more predictable. There are several studies which have dealt with the implant design and the implant material, and it has been seen that there is more inflammation with polypropylene than with a silicone plate, and final IOP control with the silicone plate model is better. But of course, it is the surgeon's experience which will determine which is the implant that you are opting for in a particular patient. So the outcome of your surgery would depend upon a good patient selection, a thorough pre-op evaluation, choosing the right implant, very good intraoperative skills, and a very meticulous follow-up. So to conclude, it is important to choose not only which procedure to perform, but also modify the procedure in order to achieve the best result for an individual patient. Thank you.